So we're really excited to be here. We're Team 13. We're here to talk about what we think is a really compelling and innovative solution to help reduce the stroke rate and bring down this problem in our population. So before we get into the recommendation, I want to lay a roadmap for today's conversation. So we'll start with Nan going through an overview of our problem, kind of quantifying the issues here, and then going what the root causes are, what the gaps are we really need to bridge with our solution. David and Tiffany will talk through our recommendations, and then I'll come back and kind of go over how this is a win-win, financially sustainable proposal for our health network. Then we'll have the conclusion and love to entertain any questions. So with that, I'm going to ask Nan to come up and talk about our problem introduction. Nan?
Thank you, Carl. So, despite current efforts by SDHN, there is a rising numbers of strokes in our members, which increase costs related to it. So, what is the magnitude of this issue? On the left, you can see the comparison of the national versus local stroke rate. Kentucky has one of the highest stroke incidence in the nation at 4.2% compared with national average 2.89%. On the sides, we use this rate to project there will be 168 strokes among our 4,000 members in upcoming 2016. This is just the stories of one of our patients, Lynette. She is a 53-year-old female whose first encounter with the provider was when she suffered a stroke. On the left, you can see some of the themes that prevented her from getting quality care. Those are low health literacy, barrier to care, financial constraint, and uncoordinated care, which eventually lead to declining health. These are some of the statements that illustrate these issues. According to her experience, she said she will wait until she becomes sick to find a doctor. And from her statement, the key findings are: patients don't seek care until they become sick. Families and caregivers are not aware of the patient's chronic diseases, and providers are not aligning and coordinating. This can result in diminished patient safety and satisfaction, prolonged length of stay, and increased costs, which SDHN is no longer willing to perpetuate. To prevent cases like that from repeating, first we need to identify where this outcome comes from on a system-wide level. This is just a conceptual frame network showing the relationship of the contributing factors, such as low health education, individualism, cost of healthy diet, distance to specialty care, and comorbid disease, which contributes the high risk and risks of stroke incidence in the population. Again, to summarize, our rigorous analysis provides the following key issues. For our population levels, we identify poor understanding of the healthcare system, little engagement in healthcare system, and lack of health literacy. And for South Tree Health Network, we identify lack of effective care coordination, EHR not universals or not fully utilized, and limited contact with our members. With that, I will welcome David to tell you about our recommendation.
Thank you, Nan. So to approach some of these issues that Nan just outlined, we brought together our multidisciplinary experience and training and did an extensive review of the literature and conducted multiple interviews with experts in the field. A few notable individuals we spoke with include the former Commissioner of Medicaid for the state of Kentucky, the director of a large primary stroke center, and the Senior Vice President and Chief Medical Officer of Highmark, one of the largest healthcare companies in the country. And all of this helped inform the new vision that we were tasked to develop for preventing stroke and providing good stroke care in the South Tree Health Network. So we were charged to come up with an integrated plan to partner with the community in reducing stroke rates and improving stroke care. And we've identified our SDHN plan members as the ideal population to target because they're the ones over whom we have influence, whom we can gather data on, and make sure that we're meeting quality targets to achieve the triple aim. And we do this with the understanding that what we accomplish and learn will inform future efforts at the state level and help shape policy as well. So here's an overview of our recommendations. We're going to start with some system level changes, beginning with the EHR, and then we're going to develop stroke teams both for inpatient and outpatient care. At the membership level, we want to screen our members and provide better education around stroke. And then for implementation, we're going to create stroke risk care plans for patients and institute a new community health worker program, which we're very excited about, that'll help bridge that gap between our provider network and the community. Now, in all of this, we understand that patients, providers, and community members are unlikely to change their current behavior unless they're motivated to do so. So we look to the latest research in behavioral economics to help design incentives to get them involved and keep them engaged in stroke prevention efforts. So we'll start with our EHR expansion project, which is twofold. One, we want to expand access to those few providers who still aren't on the system. And two, we want to create these stroke care-centric dashboards within our existing EHR, both for inpatient and outpatient care. So the outpatient setting, we're focused on stroke prevention and risk factor monitoring. And here's a mock-up here where you can see what that might look like. In the inpatient setting, obviously, we're more focused on acute care management. So as a provider, if you've ever experienced working with an EHR, you can understand how frustrating it is sometimes to try to find information that's in all sorts of different places and using that to integrate a proper care plan. And it's caused problems. As you can see with Lynette's case, her recovery was complicated and her safety was compromised because of a lack of good coordination and care and proper records. So an additional bonus to having this type of tool developed is that it offers incentives to our providers. They can take advantage of meaningful use payments and new CMS instituted chronic care management payments that went into effect this year. So the second part of our system improvements is to develop these stroke care teams, again, both inpatient and outpatient. And the ultimate goal is for all of our facilities, hospitals, and rehab centers to become joint commission certified stroke care centers of excellence. Now, the University of Kentucky Medical Center is already certified, and we can leverage their expertise to help the rest of our programs. But we've also budgeted to hire a program leader to help coordinate all these disparate and previously independently acting providers and bring them together into more of an interdependent and integrated team. And fundamental to that process for the program leader will be training these providers on these key competencies you see on the right. And Tiffany will talk more about that shortly. But first, I want to discuss our member-centric initiatives. And so once we've got the system in place to monitor their risk factors and to coordinate their care, we want to identify who's going to benefit from this and target our initiatives to that group. As you know, Kentucky has extraordinarily high rates of stroke, but also it's happening in a younger population. So we've targeted members over the age of 30, and we'll look through our enrollment records and identify them, and then filter out those who are already engaged with the system and receiving care. And we estimate about 2,500 then will be targeted for our screening initiatives. So we'll take that 2,500 and we'll outsource screening because, in the first year anyway, because of the aggressive and difficult legwork that will need to be done to really reach all those members. We'll also include a $50 gift card incentive to get those members to participate in screening. So with that, we anticipate capturing about 80%, and of those 80%, we think 80% will actually come through and follow up with the screening, or 1,588 members. And out of that, we anticipate about 60% meeting criteria for being enrolled in our new stroke care programs. So with that, I'm going to turn the time over to Tiffany, who's going to discuss the remainder of our interventions.
Great. Thank you, David. Okay, and just to point out, on the bottom of the screen, you'll see system members and implementation, just so you know which part of our recommendations we're on. So for our members, education is really key here. And so our members are in the middle since they're the most important. Our arrows are going to be two ways because our members educate us and we educate our members. So you'll see at the top our stroke care team, which we've already covered. On the left, we'll have case managers. On the right, we'll have stroke groups. Those stroke groups are going to include a primary care provider and a social worker working with our medium and high-risk patients to make sure they're fully informed about what care they need to participate in and how they can prevent further negative risk outcomes. It's also going to lower our costs as well and increase care coordination. And at the bottom, we'll have our community health workers, which I'll talk about more in a minute. On the right here, you'll have our Riskometer app. This is an application that's already in use and found to be very effective. Our community health workers will be the ones to first start using this. And it provides 3 goals. One is risk calculation, then education, and then monitoring. So for our community health workers, on the left here you'll see our selection process. So that first year of member screening, we'll be looking for folks who have their own health behaviors that they want to target, but we're also going to be looking for leaders in the community who already gain the trust of our members, people like pastors who are involved in community events and organization. Training is also going to be key. So we'll be providing motivational interviewing training. Motivational interviewing is a patient-centered style of communication. ESPER is an example of an evidence-based practice. This is used in primary care, emergency medicine, and also in the community. It really meets patients where they are and helps them form their own goals and monitor them. We'll also provide technology training for community health workers, and they're going to help us get screening in by year 2 for those mobile units. Last, our full-time field supervisor on the right here is going to be overseeing those efforts in the community and making sure that's coordinated back to our healthcare system. On the right, you'll see we have full-time community health workers. They're going to be focused on our high-risk populations who are harder to find and harder to engage. And then we'll have part-time community health workers with a ratio of 1 to 50, and they'll also be focusing on our medium risk members. So just to carry this one step further, another piece of the community health worker model that's so important is they really provide us with this line of communication between our healthcare system and the community itself. So our STHN can provide education into the community about what are the newest research found to help things like reducing smoking cessation, increasing exercise, taking good care of oneself to lower stroke risk. But our community health workers can also feed information back to the STHN about vital data that we can use to inform best practices. Continuing with our implementation recommendations, we've got a management plan by risk level broken down into low, medium, and high risk. It's going to be a tiered system. This is just a sample of the services that we're suggesting to provide, and I'll give you a minute just to take a look at that. Then we have our safety and quality improvement. This is such a key part of our proposal. So starting on the left here, patient safety. So a few things we're going to do is make sure we have standardized protocols. We're going to have safety teams that are reviewing errors that were taking place the day before. And we're going to monitor continuous training and have error prevention tools. The QI in the middle here, one of the things that we hope to employ is something I've used before called the organizational readiness to change, where we really look at who are our early adopters in our organization and who are the folks that are going to be more resistant to change, so that our program leader, who's really coordinating our stroke care team, can identify who do we need to leverage more buy-in with and who can be our allies in the beginning. We'll also have a QA committee and staff and patient surveys. On the right here, you'll see both because there's so much overlap between QI and patient safety. So again, doing those safety surveys and also flagging charts that are not completed in a timely manner, which is something we saw with Lynette's case. Key performance indicators. So on the left, you'll see metrics here. Our key metrics going to be our stroke rate and our plan, followed by secondary metrics that include things like screening costs and percent screened. On our right, we've got our outcomes here. Our key outcome, again, reduced stroke incidence, but we realize it takes time to see a significant reduce in incidence of stroke. So we have secondary indicators that we'll be monitoring as well. These include things like stroke care expenses, incentives earned, and programs that are retained. Last, just to roll back the clock, if Lynette had learned about our proposal and this was implemented before everything happened, we would have seen that she would have known her stroke risk plan, she would have participated in the program, she would have become a part-time community health worker after loving our program, she would have helped other several members to learn how to manage their own care well and become a happy and active grandmother. And with that, I'll hand it over to Kirk.
Thanks, Tiffany. So you just heard David and Tiffany talk about a few different initiatives, and you have to be thinking that sounds expensive right now. But it is. I'm here to show you that it has a high return on that investment, and this is a financial win-win for the plan and the health of our members. So before we proceed, I want to kind of do a review of a few key assumptions and then model the growth we've used in our financial analysis. So over on the left, as David talked about, we were focusing on our plan membership, the 4,000 members currently enrolled in our Medicaid pilot and our exchange product. The program has the stated goal of getting to 100,000 members, and we've used that on the right here, growing to about 100,000. And as David talked about, we have these ratios anticipating the growth of our stroke plan, the quarter of our members with the highest risk in the end, and you'll see that ratio rise as our plan grows. So that by year 5, we're really almost at 20,000 members enrolled in our stroke prevention program. We're really achieving some sort of population impact there. So here's an investment overview. And you'll see in the appendix you have a full pro forma income statement outlining all these items. You've heard about all these programs already from David and Tiffany, so I won't overview every single item. We have it bucketed under community engagement, our community health workers, our stroke registry, kind of the data collection part of this and manipulation of that data, and then coordination of care, all those system initiatives we're going to do. One thing to highlight under our stroke registry is that we have budgeted to bring in outside expertise for the analytics and the dashboard creation from a third-party administrator. Whether that's our partner Blue Cross and the South Tree Health Network or an outside provider, we want to make sure we have the right expertise so we can really manipulate that data and use that effectively from the start. Of course, these totals at the bottom are for 5 years. We're approaching $9 million here. This is a hefty investment. One thing that's very important to note is that our costs are primarily modeled on a variable basis. So if our program enrollment or scale out is either better than we expected and we're treating more high-risk members, or we find less of them and are able to connect a little less effectively, our costs will fluctuate down or up in comparison with that. And then here's the payoff. Here's our revenues from this project, in essence. Over the 5 years that we've modeled, we project reducing the amount of strokes in our network by over 400. We've projected here moving from that 4.2% stroke rate, that's average for Kentucky, down by 0.1% per year. That's just one less member per 1,000 having a stroke. I think this is an achievable change. And you see the benefit here on the bottom. As our plan grows, as our managed members start to grow. In year 5, we're nearly $8 million in strokes that never occur, and that's a huge benefit to our program. And here's the financial overview. You see here up on the top corner, our 5-year net present value is over $2.46 million. And that's the sum of the costs and benefits over the next 5 years, discounted for future cash flows being a little more uncertain and a little bit less reliable to forecast. And then you'll see them modeled through the 5 years. No year requires more than $1 million investment, and in year 4 it turns as our program enrollment grows and we really start to take hold with those members we've been touching for a few years, bringing down the risk factors. We start to see a huge benefit. It's important to note here, our savings are only modeled on stroke claims themselves. We felt that there's a lot of externalities, other cardiovascular health improvements and overall health claim reductions we'd see as a result of this program. Over on the right, in keeping with our theme of taking responsibility for the strokes in our network, we recommend focusing on total cost of care contracting for our network. And then as we are successful and begin to treat members, considering partnerships with public health and education. And so to conclude, you'll see here the diagram that David and Tiffany went over for you, our system initiatives, our member initiatives, our implementation. We feel that this will help the South Tree Health Network hit our triple aim. We'll have better care, better health, and we'll reduce our costs. And with that, thank you for the time, and we'd love to tackle any questions you guys have.
Well, thank you very much for that. Right, ready to start? Sure. So
Did we?
the dashboard that you showed on system improvements, I guess, go back to that. So would that be available, I'm assuming that would be available for the providers? And do you envision that's something that, in this case, Lynette could be plugged into as well, so something she could work off of? What's your
Yes,
thought on that?
yeah. I didn't mention that, but we would have a simplified version available through an existing patient portal. So it would be integrated into that. And Lynette could connect and communicate with her providers through that system as well.
So the program leader that you mentioned, that position, tell me about the qualifications, what you'd be looking for in terms of people to be in that role.
Sure. So after interviewing a stroke coordinator of a major healthcare system, she was a nurse practitioner. We thought she had the perfect set of skills, someone who had the clinical expertise, but administrative skills as well, and also the respect and the experience of working across many different disciplines.
So how many of those positions do you, of that program leader, is there one, is there 10? Or
Currently we've budgeted for one, but
Okay.
we'll also have our field supervisor managing our community care. So they'll be supervised by the program leader so that there's that constant coordination back and forth.
Okay.
Julie?
Thank you.
Thanks. I may have missed this, but it would be helpful to hear who and how the risk stratification would take place and on what criteria.
Yeah, so if we want to switch over back to that slide. Yeah, so the low, medium, high risk criteria would be based on risk factors published by the American Heart Association. The top 4 risk factors that influence stroke rates include things like age, weight, smoking status. So those are the things we would target, and based on those criteria, we would the system in the EHR would automatically risk stratify people to high, medium, and low.
The system would automatically.
So
You'd have it embedded in the EHR, or
that's
you
right.
have
So
a
as we screen
clinician
individuals
looking
and
at
enter
it.
their information, the system could pull things like BMI, their age, their smoking status, and then automatically stratify patients and create registries that we could use for analytics.
Okay.
That's part of our investment from the third-party administrator, getting somebody who does disease management and kind of does that on a data basis already.
Good. That makes a lot of sense. Thank you. And the other question I had is, you have multiple systems coming together to create a large integrated system for this population. Who's going to do the chart review, and how will people play well in each other's sandbox for this?
I think that might be for the quality assurance, probably, like the integration part.
Uh-huh.
We will make sure that there is effective communication among our system. For example, in this case, to minimize the complication, we will have standardized protocol, which we practice. And for the communication part, to make it effective, so we will use the error prevention tools when we are communicating to ensure that clear information has been passed around to our team, our different team members.
Mm-hmm.
And also at the beginning of the shift, when in the hospital setting, in the institution, there's always changing the shift. At the beginning of the shift, we want to make sure that huddling take place, led by the huddling process, that led by the I would say the line leaders in each individual group, to inform all of the maybe nurses or pharmacists or provider that the changes currently take place in the new system.
So it'll be hardwired within the processes that exist?
It will be hardwired as well as the active I would say hardwire, including the actual participation at the beginning or in the middle of the shift, if it is necessary.
Thank you.
We're also going to be providing incentives to the providers as well.
And that would be?
So looking at performance evaluation as one of those, and also acknowledging clinics that meet certain goals as well in terms of reduction of strokes. And readmission rates.
And I might add to that, just
Readmission rates, that's a good one. Yeah.
we're also trying to create a new culture around stroke prevention. And you mentioned, how are you going to get all these disparate providers to kind of
Yeah,
come together and
yeah.
work together? And the program leader is really going to be taking charge of that initiative. And also our push to become these stroke centers of excellence are going to create, we hope, kind of a culture in which providers are starting to come together and seeing themselves as part of a team. We've also budgeted and set aside time for training these groups in things like motivational interviewing and using the new EHR dashboard to communicate with each other and better coordinate care so that they feel like a more cohesive team.
Okay, you indicated you're going to be doing patient surveys of their experience, and that's and didn't hear a lot about that and what you had to say. And it strikes me, I look at Lynette and kind of wonder what kind of feedback we would get from a Lynette, so to speak, and how we're going to really capture that information. And in particular, since family support is such an important part of this, one of our thoughts that we've had here is that we really need to not just have patient's direct experience, but the patient and family experience and the use of the family to be a support system, et cetera. Any thoughts on that?
I do have thoughts on that. So I have a lot of experience in surveys and survey methodology and rolling them out to difficult to locate and untrusting populations. So I think our community health workers will be getting surveys annually with that riskometer and other technology, visiting the home. I've worked with community health worker programs in the community with these kinds of populations. We'll do annual surveys as well with our staff and with our patients, but also having tablets in the waiting rooms where they can provide that kind of feedback right on the spot.
Now, do you think Lynette would do that?
I think with a community health worker, she would. I think with a peer, there's a very different kind of trust relationship there.
And how about the whole use of the family and the engagement of the family, both in the prevention and in the care?
So I can speak a little bit to the prevention. And we didn't have room to put everything on this slide, but for our high-risk members, part of the plan would be to involve their family and social support network in these group visits as well. And again, the community health workers play a key role in kind of being the intermediary between the family, the patient, and the rest of the care provider team.
Okay, and as you know, our network is combined of a bunch of independent groups seeking to work together. So your recommendation about taking full risk sort of makes me wonder, particularly initially, because it seems to me that, first of all, we don't have much of a balance sheet, so to take full risk, the ebb and flow of claims, et cetera, there's a lot of cash required for that. So my thinking, anyway, going into this and awaiting your report was, maybe we start with something that might be a reward-sharing type arrangement so we get to understand the data and get to pull the data from so we understand exactly what the costs of care and the variability are. So I kind of wonder about your recommendation of going to full risk. Perhaps you could elaborate the rationale for that.
Yeah, so it aligns with our goal of really taking responsibility for it. I would note that we projected no stroke reduction in 2015. We're talking about contracting for 2016 and onward. So it does align with the time frame where we expect to really have some effects in our population. And the other reason is because if we're not set up to see the benefit of this, it's really hard to justify investing this much in the way of resources in this program. So it kind of aligns through that.
Yeah, it seems like when you have a really good program, as you're presenting here, you get some risk of adverse selection, namely those who are at high risk will choose our program because they see this beautiful integrated system of care, which means we're going to get adverse, by comparison to a norm, of member risk. So the risk part of that concerns me a little bit, is what I'm saying. So it seems to me that if we have the data of just what our membership is, and we can share in upside improvement from that base, that's a pretty good starting point. So I am a little concerned about the idea of ultimately you could build to bundled payment and to full risk, and so I think long term, with that in place, that makes sense. What do you think about that analysis?
That's a great point. I think there are a lot of risks with the adverse selection initially. I would think that if we do receive adverse selection, it comes with the reward that we're going to do a better job of retaining those members. So we'll be the ones to then see the benefits. It's not like we're going to bring in high-risk members. We're going to engage them better than any other plan they've ever had. They're going to stay with our program, and then we'll see this benefit eventually. So you make a great point about making a transition to the total cost of care contracting. That might be a smarter move as we move into the future, but it's definitely the end goal because we need to see this full benefit on our balance sheet and not on the insurer or not on.
Fair enough.
I think we're on time.
Oh, over there? Okay, good.
And will this be recorded, do you think, so we can hear the feedback?
Okay.
Great. Okay.
And it might be helpful if what are your expectations? What would you like to hear?
I mean, one of my questions is just what you think about us introducing community health workers in this way.
Love it.
Great.
Very creative.
Thank you.
Really, really creative. What jumps out at me with that is what it seems to be a very effective way in any community, but in particular a community like this, where where there's not a lot of depth in terms of education, just overall awareness of living a healthy lifestyle, and how effective would it be to be looking at your pastor, if I heard you correctly, right? It could be potentially a pastor, someone well respected in the community who's also stepping out and talking about health. So I think it was very creative.
Great, thank you.
Yeah, I'd add, I agree with that, and I think using community health workers to engage a social network, family and social network around each patient
Great.
makes a lot of sense.
Thank you.
You got the one concern I had, which was the looking at the realistic financials of risk assumption. But I think your point is long term, you do want to get there. But knowing and understanding, getting the data from the health plan to see just what's the start point? Because experience with the health plan, sometimes they're perfectly happy to give you a risk contract on a population that has a lot of adverse selection, and all of a sudden you're cooked. But I think the ideas are great. Your analysis of the issues and keeping Lynette front and center, pictures of her and everything else, very, very well done.
Thank you.
That was
Very
saying.
well thought out.
Yeah.
And it was easy for me to follow your logic, which I think is great because you're throwing a lot of information at us. 20 minutes is all you have to do what you're doing. And I thought it was very effective, and you would go back and kind of recap and then go a few slides and then go back and recap. So for me, it was very easy to follow. So thank you for doing that.
Thank you.
I thought your presentation, especially the slides, were clean and smart and very easy to follow, so I commend you for organizing your work so well. I was impressed by the total creative engagement of community. It's these networks that are going to be able to get things done. I also appreciated your definition of population. We're seeing more and more it's just not a population defined by disease state, but also by risk state. So the stratification inside that, I think, was very well done. Your nod to behavioral economics research was helpful. It gave me confidence that you're just not throwing incentives on the wall, but really put some time into that. I thought you did come back to the triple aim, but throughout you might have connected it more sharply. Here we're talking about better health. Here it's better care, and and then the variable nature of investment was a nice point that I thought was helpful, and in part mitigated some of the concerns, but not all in terms of how you progress to risk.
I think you did a good job of analyzing the Lynette case. So, I mean, it wasn't quite a fishbone diagram, but it was something like that said, here's all the issues. I would have been really impressed if I'd seen a process map of the idealized care system that highlighted all of the gaps and defects in what happened. I mean, you said we need the coordination, we need the EHR, whatever, but so what would a system of care implemented by this stroke team look like?
Kind of like
From
a
the patient
pathway?
perspective,
Right,
exactly.
okay.
That would have been, I mean, it's clear you're thinking that way,
We had
and they
that
were going
slide,
that way.
but then we had to pare
Got
down.
deleted.
Yes.
Yeah.
Okay, well, I mean, yeah, I went through your appendix. Was it in there?
No, we didn't put it in there either. We had to pick and choose. So, we wanted it to be fairly concise in the appendix. So I hope that what we delivered was helpful.
Oh, you did a really good job.
Thank you.
Well, the map, the dashboard is sort of the gauges to measure how the map is
Yes.
is performing. So
Yeah.
it would have been nice to see
See
those
that.
together. But I once heard this phrase and it's always stuck with me that stories compel and data convinces. And the Lynette story was very compelling and well presented, the qualitative part. So
Thank you.
Thank you.
Great.
Yeah, I just would maybe finish up just overall, just presentation skills. I thought very well done. Great start to the day for us, so thank you for that. But I'm impressed. You all seem very comfortable with what you were doing. Just basic PowerPoint etiquette. You didn't rely too much, looking back at the slides you were using the computer. So I thought that was very well done overall. So, well done.
Thank you.
Thank you.
All right.
Clearly a team.
Thank you so much.
Clearly
We
came
did.
across as a team.
That we are.
We did.
We are.
Yes. Thank you so much.
Thank you so much.
Do I have everything?